Okay, I don't know if you can see me or not. Everything says my camera's working, but I don't see me up in the corner. So if it's not, sorry. Multimodal analgesia. It's kind of a newer concept in veterinary medicine, but we're learning. So we're going to learn about how we can, the same as the balanced anesthesia, we can have analgesia that comes from different directions also to give us good analgesia, better analgesia than any one single drug alone with a lower dose. So analgesia, what does that mean? The absence of pain in response to a normally painful stimulus. So there are a few analgesics, particularly, well, let me back up. Analgesia is not the same as anesthesia. So when we're thinking about total absence of pain, with analgesia, we don't really get that. It takes anesthesia to get total absence of pain. And then local anesthesia is the only 100% anesthesia. So with analgesia, I want to say absence of pain, but it's more like a reduction of pain. There's nothing that's going to make you feel like you don't hurt at all. Hyperalgesia is an increased response to a normally painful stimulus. So once those nerves get fired up in a situation, they become more sensitive and more easily turned on. So in that case, we get that hyperalgesia where, yes, we expect it to hurt, but it's hurting a whole lot more than it should. And that kind of comes with chronic pain or with continued pain applied to the same area. Allodynia, on the other hand, is pain that's when you get a painful response to a stimulus that shouldn't be painful. So for this one, think about if you have a sliver in your finger and that you can't get it out, it gets infected, it gets swollen, it gets painful. And then just touching it on the table is going to make it hurt. You reach out to turn on the light switch and forget about it, and that really hurts. So that's allodynia, and that's when those nerve endings are so fired up that they're going to blast off a signal when there's just the contact which would not normally cause pain. Okay, I don't know if you can read the whole thing if my camera's there. If you wait until an animal shows sign of pain before treating with an analgesic, a higher dose will be needed. This is true, and not much of a question, but if you think about it, we used to not give pain medication until we had a reason for it. We didn't give pain medication pre-op. We only gave it post-op if they were crying more than usual. So we were missing a big opportunity to lower the dose of the pain medication and make it more effective if we gave it before the pain was created. And we'll talk about why that is. Inflammation comes from tissue damage. Tissue damage, anytime cells are ruptured, chemicals are released. It's their communicating chemicals that they send to the cells around it. Vasoactive, meaning they work on the vascular system. The vessels in that area open up. The pores in those vessels become bigger, so they can be leaky. So serum and white blood cells leak out of the vascular system into those tissues. You need, that's what causes swelling. That's what causes redness. Then also, so those chemicals are histamine, products from the leukocytes themselves as they get ruptured, and proteolytic enzymes, so enzymes that break down protein. Arachidonic acid is present in cell membranes, and when they are ruptured, then the arachidonic acid comes out, and arachidonic acid our body metabolizes to create prostaglandins. Remember that word, we talk about that one a lot. Come on. Roller on my mouse doesn't like to work. And I've given you this before in previous lectures, and I will probably give it to you again. It's an important concept, and you really need to understand this. Pain or stress cause that fight or flight nervous stimulation to happen. Your body says, uh-oh, something bad is happening. We got to protect ourselves. We either have to fight it off or we have to run away. So the epinephrine and norepinephrine that I released increase our heart rate, our blood pressure, respiratory rate, our pupils get dilated, we are ready. It also causes the release of cortisol, that's our stress hormone, and cortisol actually delays healing. I can't give you a real simple explanation of that, just understand. Cortisol release delays healing. And then you'll get some non-specific physiological signs like a leukocytosis, maybe a neutrophilia, maybe a lymphocytosis, hyperglycemia, polycythemia. So the neutrophilia lymphocytosis, we call that a stress leukogram. When you see that white cells in general are elevated, but your neutrophils are down, your lymphocytes are up, maybe not even out of the normal range, but in relationship between those two, that tells us that there has been some sort of stress going on. This can be physical stress, it can be emotional stress, it doesn't have to be injury. But we won't see those things until we actually take some blood. The behavioral response to pain, what we see and what we can use to decide if our patient is painful or not, varies by species and breeds. Within some breeds tend to be a little more overreactive, some breeds tend to be a little more stoic, but also individually. And just like in people, some people are really tough, some people are really wimpy. There's also a big difference in signs of pain between acute and chronic. Acute pain, you're more likely to get that acute response. Chronic pain may just make everything slower, duller. They're not as happy overall because of that chronic pain. It wears you down. And remember that our patients, particularly those prey animals, will mask any signs of pain if they know that we're watching them. And it's something we have to be careful of and make sure that we're paying attention to them when they don't really recognize. Sometimes you have to peek through the window at them if you have a window in your door to the kennel room, or walk up and be doing something else for a few minutes so they stop paying attention to you, and then watch them to see how they're really acting. So for instance, species to species. Horses, signs of pain may be sweating, kicking, pawing, they curl up their lip, they lay down or roll if they have abdominal pain. And so those signs are pretty easy to recognize, but it's acute abdominal pain. They may, horses will limp if they have pain in their bones, obviously. That's what they do. But those signs are pretty obvious, and most horses can't hide that. They can hide the more minor pain. Cattle may have the same kind of thing going on and only grind their teeth. You may have very little recognition of signs of pain with cattle. Think about dogs or canine patients. Sometimes you have that big hound dog is a good example, that they go running through the woods and they come out back and they're all torn up and they got scratches all over. Maybe they got in a fight with a wild animal and they're just happy, bouncing around, tongue hanging out of their mouth. They don't care. Versus the little toy breed that's like, ay. My daughter-in-law has a Chihuahua, and she's a sweetie pie. But you go to pick her up, and she immediately reacts as if something bad is going to happen, and cries a little bit. Then you get her up, and she's all snuggly and sweet. And then cats. Cats are really tough. They may act very withdrawn, that they don't want to interact with you. But in the clinic setting, especially, cats are really tricky. They may act perfectly normal because they are really good at hiding their pain, or they may be extra aggressive. We did a study, clinical trial when I was, this has been a few years ago, but for Onsior actually, and we did judged pain after surgery in cats. And I was the one administering the drugs, so I know who, about 2/3 of the cats got the drug that they were testing, and 1/3 got just the regular analgesics that came with surgery. So I was the one who gave the cats the drugs, so I knew which cat had which. But my friend Jackie was the one who had to evaluate all the cats, and I couldn't give her any clues. She had to be totally ignorant of which cats got what. So I usually wasn't even around when she was, because I have kind of an expressive face. I have a hard time hiding that behind a mask. Anyway, she would find these cats and go in, and they had been declawed and altered. So she had to pinch their toes, she had to feel their incisions and see what kind of response that she got. And there were some cats that woke up from surgery just mad and screaming and hate you. And those cats had to be withdrawn. They were considered painful. We had to rescue them. Rescue meaning we gave them another form of pain medication. Then she would come in. There were some cats, there was one Persian, but he was a intact male, 3 or 4 years old. He was a big, tough guy. And that cat went the whole time, 3 days after surgery that they had to stay in the clinic. And he ate normally. He acted fine. He gave absolutely no signs of pain. And I know that cat got nothing for pain from the time he woke up. So it was really eye-opening for me that you think you know when they're painful. You don't. Come on, turn the page. Back up. One more. There we go. Okay. Acute postoperative or traumatic pain, that animal who's had a trauma, been hit by a car, kicked by a horse, whatever, you may find that they are biting the source, licking at it. A lot of cats, especially, you put in skin sutures and they'll go right after that incision. They're not awake enough to walk yet, and they're already trying to pull those sutures out because they look down, they see that, they think, I'm anthropomorphizing here. They think my tummy hurts and those things are there. That must be what's making me hurt. They may also do pacing when they're painful. They won't lay down. They can't get comfortable. Guarding means that if you go to touch them on that spot, they move away, or they put their head in front of it, or even threaten to bite you if you are reaching for that painful spot. Usually sleeplessness, and that may be hard for us to recognize. Aggression. We had a dog, it was a yellow lab. It was a nice dog to begin with. He had been in been hit by a car and had some serious pain going on. And he got you had to walk in and muzzle him before you even tried to touch him, because he would bite you at the drop of a hat. He was painful in both front legs. And so it just, anything that we did to him was painful. And he just got, he didn't wait for you to touch him. He was he was defending himself. He had that right to defend himself. He wasn't being mean. He wasn't being out of proportion. He was guarding himself, protecting himself, and that's expected. Vocalization, but they don't vocalize as much as we think they should. They don't do a lot. Some dogs that are whiny, they're not hurting at all. My own dog, who you can probably hear snoring in the background, if she whines sometimes, and it's certainly not out of pain, it's because she wants something. Oftentimes anorexia is one of the things that we see. They're not eating real well because they're painful. Chronic pain, on the other hand, like with arthritis, they may just be withdrawn and quiet. Oh, he's getting old. We don't expect him to run and play with the ball anymore. You put these guys on a little NSAID and suddenly, hey, he's bringing me his toys to play with. This is crazy. Or another kind of chronic pain that people don't recognize is dental pain. You have that dog who has a horrible mouth. Their mouth is a mess. It's They've got a lot of bad teeth in there, and the owners don't recognize that. And we go in and we pull the teeth and we clean them up and we get everything back in great shape. And I call them 2 or 3 days later to say, how are we doing? Always feels great. I can't believe it. He's eating better than he has in a long time. And he's playing with his toys. He hasn't played with his toys and for years. And it's because it hurt to play with the toys. It hurt to eat. So, of course, they eat enough to survive, but they're not happy eating. They're just eat because they have to. Some other things that you may find with chronic is failure to groom. And we see that mostly with cats. I mean, dogs groom themselves, but not to the same extent that cats do. They'll have mats, or they'll have just clumped up fur that hasn't shed out, where they've never been that way before. And often it is because if their back hurts, especially, they can't, it hurts to turn around. It hurts to take the positions that they need to take to reach all their parts of their body that they normally groom. Reluctance to move. The dog lays in their bed most of the day, doesn't want to get up. You walk up to them, they're laying on the floor, maybe in a spot in the sun, and you walk up to them because you need to get by. They don't. Okay, they take a while to get up. Also anorexia, don't want to eat. They tend to lose weight because they will eat when they have to, but they don't eat as much as they'd like to. Constipation is a big one with sore backs because they have to crouch to poop. And if it hurts to crouch, they will put it off as long as possible. And then when they got to go, it's then it hurts and they can't go. So that's something that we need to look at. And dysuria, they'll hold their urine as long as they can too, which sometimes leads to accidents in the house because they're holding it because they don't want to go outside. It's cold and that makes them hurt more. And so they have an accident in the house. So there's recent evidence, it's not all that recent anymore, that dogs experiencing postoperative pain demonstrate significantly fewer pain-related behaviors in the presence of an observer than they do when they're alone. I'm going to show this video when we're in lecture so that we can talk about it as we're looking at it. It's really kind of sad. It's a little Westie that they set up a camera on his cage overnight, and you see what the people who are taking care of him don't see, because as soon as they walk in the room, his behavior totally changes. It's a very informative video. So our job as a technician is we are the ones that are right there. We see the animals much more often. We are giving them their medications. We're giving them their treatments. We're taking care of their wounds, whatever it is. We're the ones who are right there and seeing them. So we have to be aware of those signs of pain, understand and interpret those signs of pain, so we can be the ones that then say to the doctor, hey, this dog seems like he's more painful. Or, okay, we gave him that dose of analgesic and he's much more comfortable. Then we know that what we're using works. And the veterinarian may not notice that. The younger veterinarians, dare I say it that way, are trained better in recognizing the signs of pain. Some of our older vets, one of our really older vets, still says, and I have to talk to him all the time about it, well, we don't want to give him any pain medication because I want him to be still. I think I got that on the next thing here. Nope. I'll come to it and then have to say it all over again. But they used to think, well, if you give them pain meds, then they'll be bouncing around and hurt themselves. Believe me, if any of you have had surgery, you know that those pain medications make you able to function on some level. They certainly do not make you want to jump around on your recent surgery. Huh, Jenna? I just remember you had knee surgery, so. Okay, next slide. So since the animals vary in their response to pain, they can mask the signs of pain, we have to assume that if the procedure that was done or the injury that was done would be painful or for us, it's painful for them. That's the go-to response. If that was really hard for me when we did that cat pain study, that I knew those animals were without pain medication, but that's the rules of the study, and sometimes you have to do that. Leaving them without anything made me feel bad for them. So I'm going to put these pain scale handouts up on Canvas for you. Make my son. And I want you to look at them and go over them. They've just got some, like the one, if you've been to the doctor's office, they've got the faces. Are you happy? Are you mad? Are you, extremely painful? These kind of show the way animals look. We have some for dogs and some for cats with also some information about it. And you may have seen them already, but I want to give them to you, and we're going to talk about them in lecture so we can recognize the signs of pain in our patients. Postoperative pain control. Remember, persistent pain causes immunosuppression. Delayed wound healing, so because of that cortisol release, the wound heals more slowly, and it increases tissue catabolism. Catabolism means that you are actually breaking down your own tissues. So we don't want that to happen. We want our patients to be comfortable. We want them to not have that immunosuppression from the cortisol release. We want their wound to heal as quickly as possible, and we don't want them destroying their own tissues. Soft tissue pain is going to last 4 or 5 days after surgery. And so we need to provide some pain control when they go home. I keep thinking we're still in lab and you've had that experience, but some of you at least have had, and probably most of you have had a little experience with Dr. Tyson's method of sending home pain control for the animals. Everybody who gets surgery goes home on something, even if it's only for a day or two. But we recognize that pain control is really important. And here's what I was talking about with the older doctor, veterinarian where I worked. They used to think, and they used to teach us this. When I was in school, this was an accepted concept, that animals will be calm and quiet if they're painful. So avoiding pain control is a form of treatment. Makes me sick to say that these days. Okay, so let's have a look at this little dog. He or she is sitting with their back to the world. They're facing the back of their cage, sitting up when most dogs will lay down when there's nothing else to do. You can see the food, and that sure looks like tasty AD to me. Most dogs go crazy over that. This dog isn't touching it. It's got an IV catheter in. Just judging by the breed, I'm expecting that this is a painful back. They've got the cage nicely padded. They've provided for this animal, but if you look even around his, I'm going to call it a him because I don't know what it is, around his face, that's not a comfortable face. That's certainly not a happy to see you face. The ears are down and back a little bit. This is not looking at you saying, hey, come play with me. This is, I'd really rather you just go away and leave me alone. This animal is painful. If we manage their pain, after surgery, we expect them to sleep for several hours, not from the drugs we've given them, but because they are comfortable. The drugs they're going to, the pre-anesthetic drugs should still be on board post-anesthetically. So we've got that tranquilization. They should be just about as sleepy as they were before. When we have to go in and move them, when we get them up to take them outside before we put them in the truck, they should be pretty comfortable, that they're willing to get up, that they're willing to walk. They should be alert, interested in food, interested in the environment, want to see you. When you come up to the cage, they may even stand up and come to the front of the cage. These are animals that are comfortable. Like this dog. Up to the front of the cage, notice the relaxed jaw, mouth slightly parted. This is an invitation to interact. Ears are up, pricked forward. Eyes are looking at the front of the cage. Nice dilated pupils from the drugs we've given them. So this animal is willing to engage and not an extremely painful patient. Doesn't mean he doesn't have any pain, but we have made him comfortable, so he's not going to be withdrawn. So we hopefully, depending on the length of the surgery and what we use to begin with, our pre-anesthetic meds are going to still be on board post-anesthesia. If not, we can always give them some more. If we have pain after surgery, that means we can give them more drug. They don't have too much yet. Not that we want to get to too much. You can also do some other things that will stretch out that post-op pain control. Local, regional epidural blocks, those local blocks that we put in along the incision site, that's numb for several hours. An epidural can be 12 to 24 hours that it lasts, that numbs or relieves the pain. It's always best if you give any of these drugs before tissue insult, because once those nerves are fired up, remember, they're easier to inflame again. They're easier to, what's the word I want? Stimulate again. Consider adding in an NSAID, and an NSAID is always going to be more effective if it's given before tissue insult. For one thing, when an incision has been made, the edges start immediately with that inflammation, blood coming out, and then they start closing up and trying to clean up the job. That reduces the blood supply to that area. There's tissue along that edge that's going to die. And so the NSAID doesn't get all the way to that. The blood supply after surgery is altered to that section. So the pain medication that we've given them, that we give them after surgery, doesn't go to where we need it to go. So we want that pain medication on board and throughout the circulatory system before we start damaging tissue. So it's in the spot where it needs to be. And we'll talk about how these drugs work too. So the analgesic drugs that we have are systemic analgesics. Those are the ones that we usually think about. Opioids, the big guns to come in for the acute pain. NSAIDs for the longer lasting drugs to go home. Drugs for chronic pain. And then our local or regional analgesics. All things that we can do to help the painful patient. So opioids work by interacting with receptor sites, mostly in the brain, but also in the spinal cord. And there's several receptors. We're just going to talk about the mu receptor and the kappa receptor. Those are the ones that are affected by the drugs that we deal with the most. The mu receptor is responsible for analgesia, respiratory depression, sedation, euphoria, and addiction. So that mu receptor, once it gets its drug, it likes that drug, and it's the one that asks for more and more. Kappa gives you some analgesia, not as much. The mu receptor is our stronger analgesia. The kappa is not as strong. It causes some sedation, not as much as the kappa, but less addiction. So you're less likely. So opioids that are kappa, that bind mostly to the kappa receptors, are less likely to cause addiction. Opioids that bind to the mu receptors are most likely to cause addiction. The pure agonists, those only stimulate the receptors. They bind to it and they make it do what it's supposed to do. Antagonists, remember, bind to the receptor, but they don't have any action there. They don't make the receptor do anything. They just cover it up. It's like a cap. Agonists, antagonists, some drugs are a little of both. They stimulate some receptors and antagonize or block other receptors. The cardiovascular effects of opioids are dose-related. So when we can give a smaller amount because we're mixing it with something else, we get fewer side effects. Bradycardia, it's always going to slow down the heart rate, and hypotension. In our surgery patients, we certainly don't want a lot of bradycardia and a hypotension. We've come to understand that some slowdown of the heart rate is okay during surgery, but we don't want it to get to the point where it's so low that we have to give them other drugs to speed up their heart. And hypotension, we know, is bad surgically because all the drugs we give them cause hypotension. We end up with a situation where the animal doesn't have good peripheral circulation and we could start having some organ damage. Remember, it's the kidneys that are most acutely responsive to hypotension and the ones that will have a problem as it goes on if we have too low of blood pressure for any period of time. Respiratory depression is also dose-related. Not as big a deal in animals as it is in humans. But it does give us a decreased rate and decreased tidal volume. That's why, a normal dog's respiratory rate opposed to an anesthetized dog's respiratory rate, big difference there. That also decreases the sensitivity to CO2. So we have to watch that. That's why it's great to have a capnograph. We watch that capnograph because it will normally, when your CO2 goes up, you breathe harder, breathe deeper, breathe more often. When you're have an opioid on board, that is, our threshold is much higher, so we can tolerate a lot more CO2. But buildup of CO2 not only means our tissues aren't being as oxygenated as well, but it also means that we have some like increased intracranial pressure, which we don't really want that to go on in our surgery patients. So we have to think about maybe assisting breathing. We don't have to totally breathe for them, but giving them that deep breath every 5 minutes. Or if our CO2 is running high, we may have to every minute give them a nice deep breath to help blow off some of that CO2, because they're just not being stimulated to breathe more. They cause salivation, sometimes profuse, especially in cats, but sometimes it's the dogs too. The spit's just running out of their mouth. Does cause vomiting. Usually it's only once. They vomit after you give it to them. It's not like, oh, if you give them this, they're going to puke all day. And may cause diarrhea. That's generally, again, a one-time thing, but sometimes it's actually while they are under anesthesia or right after the anesthetic period, they wake up and they squirt diarrhea all over the place. Sedation and dysphoria are also dose related, and some drugs, we'll talk about, some opioids are much more sedative than others, and some are more likely to cause dysphoria than others. They're all extensively metabolized by the liver, so that means with our patients with a liver problem, or our older patients, our very young patients, we're going to, it doesn't mean we can't give them opioids. If they are having surgery or they have had trauma, they deserve an opioid. We just reduce our doses. We can always add in more. If you give them a low dose and it's not enough, you can give them a little more. We may need to stretch out our time between doses because they're not metabolizing it as quickly. Doesn't mean we can't give it to them. We just have to be aware that they're not going to metabolize it as quickly, and don't just walk in and give a dog who's still gorked from the first dose its second dose because it's time. Pay attention to those signs. They are all controlled substances, which means they have to have a DEA license, require special handling and paperwork. We have to keep good records of every animal who got it, who their owner is, and especially if we are dispensing these opioids, it's very, very important that we keep track of it. A lot more paperwork than it used to be. All right, let's talk about some of them we use. The pure agonists. So these are drugs that stimulate those receptors to do their job. Morphine, that's kind of the original. That is, morphine is refined from opium, and opium was the original narcotic that was used. And they used it for pain, but they was also quite commonly recreationally used a couple hundred years ago. Maybe not even that long ago. Anyway, morphine is a natural substance. Can be given IV. If you're going to give it IV, you got to give it slowly. It can cause especially dogs to really freak out if you give that too fast. Can go IM or sub-Q, intra-articular, epidural, oral. There's a bunch of ways to give it. If you're going to give it epidural or intra-articular, you have to get the non-preserved kind. You don't want any preservatives going in those spaces. It's good for moderate to severe pain. This is the opioid that all other opioids are measured against. It does have much more gastrointestinal effects than some of the newer drugs. It causes vomiting. It causes GI stasis. So at first they may have diarrhea, and then after a day or so on those drugs, they get constipated, really, really constipated, just slows the whole gut down. Cats, recommended never to give that drug IV in cats, although I have given, not morphine, sorry. Wait, getting ahead of myself here. And they need a much lower dose, or about half dose of what dogs get. The side effects are all dose related, just like all the drugs we're using. The side effects are more pronounced if you give this when they're not painful. So with the opioids, we know when it is taken for a painful situation, you're much less likely to get addicted to it. But if you continue too long after the acute pain has subsided, you keep taking that opioid, that's when the addiction sets in. That's when your body starts saying, instead of, oh, I don't feel painful anymore, they start saying, whoa, I feel good. So we need to, and with our patients, the chance of addiction is pretty low because they can't go to the drugstore and pick it up themselves. And when the owners stop giving it to them, they're not going to get any more. But that's how opioids cause addiction. Fentanyl. Fentanyl is a synthetic, totally man-made. It's very potent. It has a very rapid onset but short duration. This is not a drug that is effective if you're giving an injection pre-op. It is not going to give you a very long period of effectiveness at all. It does cause a lot of panting and increased sensitivity to sound. So something in the animal may be sound asleep. Somebody drops something metal on the floor and they freak out. Profound bradycardia, respiratory depression when it's injected. It is also very good for moderate to severe pain. This is a big gun. It's most commonly used because it's so short acting. It's used as a CRI, and the CRI is very effective with fentanyl. You calculate it out how many mg per kg per hour you need, and you give it to them at that rate. And the great thing about it is, if they're too sleepy, you slow down your rate. If they aren't, if they're still painful, you increase the rate. It's very easy to minutely change that dose. Where if some of the other opioids that you're going to give as an injection, once it's there, and you end up with, you've got a painful situation, you give the drug and it goes to a high, non-painful situation, and then you go back down the slope to pain. It's time for the next dose. With fentanyl, you get a nice even, you don't get that big high in the middle, and you don't get those lows. You get a nice even level of pain control. If you can't see me, I'm using my hands anyway. If you can see me, you know that already. So the CRI is great. They also make the fentanyl transdermal patch, and that can be applied to animals. It's real important that you put that in a place where they can't get to it and chew it off, because it's got a three-day dose of fentanyl inside of it. And if they chew it, they're going to get that whole 3-day dose all at once. There's been a lot of movement away from that patch because of stories, and not just stories, it happens. You send an animal home with a fentanyl patch and the owner takes it off and puts it on themselves. Or the owner, I've heard stories of nurses in hospitals putting a needle into the fentanyl patch and sucking the drug out and giving it to themselves. So it's not as, it was a great thing, we thought, when we first had that opportunity, but there's some drawbacks to it. Okay, oxymorphone. Oxymorphone is semi-synthetic. They've taken morphine and changed it up a little bit, so it has a longer duration than morphine, lots longer than fentanyl, 4 to 6 hours. It doesn't cause vomiting as much as morphine. It tends to be just once after injection, and not a big vomit, just a kind of a little bit. It does cause panting, bradycardia, increased sensitivity to sound. It's kind of an opioid thing. This is excellent for moderate to severe pain. It's expensive. Oxymorphone is an expensive combination, or an expensive drug, sorry. Hydromorphone, semi-synthetic. It has all the same characteristics of oxymorphone, but it's really cheap. I don't know why oxymorphone is so much more expensive. Probably whatever they do to make it, to alter the morphine into to make it the semi-synthetic is an expensive process. Where hydromorphone is the same thing. It is semi-synthetic, does all the things that oxymorphone does. It's really cheap. It's like pennies per dose. So agonist, antagonist, butorphanol is a total synthetic. It has weak agonist properties on the weak antagonist properties on the mu receptors and strong kappa agonists. So stimulating. Where did I get that from? Anyway, stimulating the kappa receptors. The advantage of knowing this combination is if we've used hydromorphone pre-anesthetically and our patient is waking up and they're a little bit painful, we'd like to give them some more. Or they seem to be doing fine, but we know we got to send them back to the shelter, and we don't want them to, our hydromorphone that we gave them pre-anesthetically is going to be worn off about the time they're heading back to the shelter, and we want to give them some more pain control to last them through at least the evening hours. You can give this drug on top of the hydromorphone. It's not going to be an overdose. You don't want to give them both at the same time, but as at the end of the hydrodose, you can put in this butorphanol because it's going to antagonize the hydromorphone but still stimulate the kappa. It's going to antagonize those mu agonists, and I'm sorry, I'm getting myself mixed up here, and agonize or stimulate the kappa receptors so that we get some pain control, but it's going to last longer. This has a ceiling effect on respiratory depression. It does not ever go to the point where the animal is breathing so poorly that that we're not sure they're going to survive. It also is antitussive, which many of the opioids are. Antiemetic, as other opioids usually are not. It's a great antiemetic for cats. If you have that cat that's vomiting for whatever reason, maybe they're in kidney failure, and we're working on getting their kidneys flushed out, but they just feel awful and they don't want to eat and they're vomiting. Give them a little butorphanol. It's a nice, gentle opioid for cats, doesn't freak them out, and so a lot of times they will stop vomiting and even start eating for you because some of the pain is gone and they don't feel nauseous anymore. The problem with this one is it's a short duration, only about an hour, and they may be sedated for much longer than that. So we used to think this was giving us long-acting pain control when it's really only giving us long-acting sedation. It's good for mild to moderate pain. This is not our very best pain medication. And unfortunately, how do I want to say this? It's not unfortunate. It is widely used in veterinary medicine, and it's good where it's good. But sometimes we rely on this for our major pain control when it is really not the best drug. And if you compare the price of butorphanol to the price of hydromorphone is a much better analgesic at a fraction of the cost of butorphanol. So if the vet doesn't want to try it, talk about, I'm going to save you money if we start using this. Buprenorphine. This is also an agonist-antagonist, and the other way around from butorphanol. It's a synthetic, so it's a partial mu agonist, so it works, but it's not a real, doesn't stimulate all the mu receptors, and it has minimal kappa effect, so it kind of stays away from some of that stuff. But even though this one's a mu agonist, it is less sedative than most of the other opioids. This is my favorite opioid for cats. It works, doesn't make them too sleepy, usually makes them really, really happy, and it is the best pain medication, makes them comfortable. Can be given orally, although it is extremely bitter, and you may get it into them once or twice, but you're probably not going to get it into them after that because they see you coming and they hide. Obviously, when they're in the hospital in a cage, they can't hide from us, but it's nasty tasting. It takes a while for onset. This one is like 15 to 60 minutes onset, and it's hard to tell, exactly in an animal when it takes its effect because it's kind of a slow buildup. but it has a really nice long duration. And with cats, the higher the dose we give, the longer the duration is. It has the effects go only to here and they never go any higher. It's that duration. It takes them that long to metabolize it and get rid of it. So that's what Symbidol does. Symbidol is just a big dose of buprenorphine. That's why it works for 24 hours and it's only in cats. It's not, unless they've changed it, it's not for use in dogs. It's just for use in cats because dogs don't have that same ceiling effect with buprenorphine. This is good for mild to moderate pain, but it really is the best analgesic, the best opioid for cats. Respiratory depression, I told you less sedative effect. The respiratory depression that is there is if you need to reverse it, and I've had very few cases, and those were all in dogs, where the respiratory depression came to a point where there was some concern about it. But this opioid, buprenorphine, has strong affinity for those receptors. So it's hard to kick it off and put a cap on it. So the naloxone doesn't work well to reverse buprenorphine. If you have respiratory depression, doxapram, which has become an extremely expensive drug, and you may not have it in the hospital, may work better for the respiratory depression. Like I said, I've had very, very few cases where the animal was depressed enough to think that I needed a reversal with buprenorphine. Tramadol. Tramadol is an oral opioid. It was in use with humans for quite a long time before we started using it in animals, but it used to be not controlled, which made it nice. We could send it home more easily. It is a mu agonist. I have taken it a couple of times when I used to have back problems. It didn't do much for me. But with some animals it works real well. Some people it works real well. It's safe for cats. Obviously, you're not going to give the cat a whole pill of it. It needs to be compounded into smaller doses for the cats. Sometimes it causes some upset stomach, some diarrhea, some panting, but not nearly to the extent of some of the other opioids. It also causes less bradycardia. This is a kind of a lightweight to send home. What we have found in dogs is this drug works better when combined with an NSAID. The two of them together work very well for pain, especially joint pain, back pain, more the chronic kinds of pain. The problem is people were becoming addicted to it, and in needing it for themselves, they were giving it for chronic pain in their dogs, or getting their prescription for chronic pain in their dogs, and then abusing it themselves. So it's become controlled now. It's much harder to dispense, to send home. So the antagonists, the big one is naloxone, and there are different brand names of it. Narcan, I can't think of the other ones, but naloxone is the generic name. It's a pure competitive antagonist at all the opioid receptors, meaning it goes in and it blocks all those opioid receptors, does not stimulate any of them. It is not controlled. They talked about making it controlled, which I'm sorry, that's dumb. The drug that could save someone's life, making it unavailable. It's not controlled. IV is the way you should give it for immediate effect. Can also be given IM and is also effective IM, just takes a little longer. If you give it IV, you should have an increase in respiratory rate, which is the big thing in humans. The opioids will cause a human's respiratory rate and depth to go so low that if you die from an opioid overdose, that's usually what happens. You go into respiratory arrest, and that leads to cardiac arrest. So 1 to 2 minutes and you're breathing normally again. The antagonist effect only lasts 1 to 4 hours. So if we've given a longer acting opioid and then we have to reverse it, we have to think about, okay, we're going to have to give this dose again, and make sure that you're monitoring your patient and recognizing the signs of them getting too sleepy or not breathing enough. We're not going to give them another dose of that same opioid, certainly not in the same dose. We may give a lower dose, but when when we notice that they are getting real sleepy or real depressed again, then we need to give another dose of that antagonist. If you give a lower than the required dose, you're only going to antagonize the mu receptors. You need higher doses to get to those kappa receptors. So the advantage that we have here, and you may have experienced this in lab when we had a dog that was sleepy after they should have been up and around, they were still laying there with their tube in. We give them just a little bit of naloxone, and within a couple of minutes that's in their system, and it's just partially reversing, partially antagonizing, and we get them more awake without taking away all their pain control. If you give the full dose of naloxone to an animal who's waking up from surgery because they're too sleepy, now you've taken away all of their pain control. This was years ago when we first started using the opioids. We had a dog, and I do not remember what its problem was anymore, but it was having a big surgery, and we had used the hydromorphone as a pre-anesthetic, and during surgery his respiratory rate was down, and his heart rate was down, and doctor said, you got to reverse the opioids. So we gave him the full dose of naloxone, and then the dog was huffing and puffing through the whole surgery. We couldn't keep him in a good surgical plane of anesthetic because we took away everything. It wasn't until later that I learned you can only give part of that dose that will take away enough of the respiratory depression and the bradycardia to get them back to a better plane of anesthesia, a more survivable plane of anesthesia, without taking away all of their pain control. Opioids together with a tranquilizer is a good combination. The tranquilizer counteracts some of the side effects, makes the opioid work better, so we can give smaller doses of both of them. Acepromazine has an antiemetic effect, which will help to reduce the emetic effect of the opioid, especially when we're looking at that post-op period. And with our animals, especially our shelter patients, the pre-op period, there's a lot of anxiety. They don't know what's going on. We're poking and prodding and doing weird things to them. They don't understand. And it's amazing that our patients are as cooperative as they are. But that tranquilizer helps them to relax, takes away their pain or their anxiety, which then helps the pain medication work better. NSAIDs. NSAIDs are a great tool. They're not controlled. They are good analgesics, antipyretic, so they're good for animals with an elevated temperature, anti-inflammatory. And the way NSAIDs have their anti-inflammatory action is they inhibit cyclooxygenase. Remember, cyclooxygenase is, I don't know if I have that in this lecture. Nope. Okay, I'll just tell you. When we have cell damage, arachidonic acid is released. With the arachidonic acid is then metabolized to form cyclooxygenase, which is metabolized into prostaglandins. And prostaglandins are a good thing. We don't want to be totally rid of them, but there's different forms of prostaglandin. There's a lot more than just the two that we talk about, but a COX-1, cyclooxygenase 1 is a gastroprotective form. That's the one that makes the slime layer inside your stomach that protects your stomach lining from the stomach acid. That's why NSAIDs cause stomach upset. Not because the pill in your stomach causes your stomach to hurt, but because the older NSAIDs like aspirin and ibuprofen are total COX active, and so they block the COX-1 and the COX-2. So they get rid of that gastroprotective form that gives us that slime layer, and so our stomach is more affected by its own acid. COX-2 is the one, the cyclooxygenase, that is associated with inflammation. So the newer NSAIDs block just the COX-2 and are COX-1 sparing, at least to a certain degree. And as we go along, we're learning that there are more of these cyclooxygenase types that are involved in different parts of the whole situation, the whole inflammatory cascade, and they're working on it all the time. People a lot smarter than me. NSAIDs can be peripherally, we used to think it was just peripheral action, that it worked on the source where the inflammation is starting, but now we also know that they have some central acting properties to help control the pain also. So aspirin. Aspirin's the original. It is the first NSAID. Causes a lot of gastric irritation. It increases the bleeding time, and it does this by directly affecting platelets. Any platelet that the aspirin affects is, for the rest of the duration of that platelet's life, is not effective, cannot clot, cannot clump up, cannot create clotting. Aspirin has a really long half-life in cats, in young animals, and in old animals. It's just, it's gone out of use for most human uses. They still use it because it does do that platelet, it affects your platelets, makes them no longer useful. It is helpful for people who have heart issues, heart attack issues, because the platelets are part of what blocks the arteries. So if we can keep them from clotting, but it's not enough that they take a low dose, so it's not enough to destroy all the platelets, just reduce the clotting or increase the clotting time. Acetaminophen, Tylenol, is less potent than aspirin. It's often lumped in with NSAIDs, but it's not really, doesn't fit the non-steroidal anti-inflammatory. It has less gastric irritation. It has a weak anti-inflammatory effect. It's not real good at it. It is hepatotoxic to dogs. In humans, in higher doses, if you take too much of this, it is hepatotoxic big time. So you have to be careful with this drug. It's not, they touted it when it first came out. It was the first alternative to aspirin, and oh, it doesn't bother your stomach. It's so good. It's so safe. It's so, it's not. So it's something that we need to be careful with, and it is not useful in our patients. It's very toxic to cats. I don't think I have it in this lecture, but I'm going to tell you. You can look it up if you want to. In fact, I'd like you to look it up. Look it up. We'll talk about it in class. What does acetaminophen do that is so toxic to cats? Like death. Ibuprofen, that was the first new NSAID in a long time. It does have renal effects. It directly reduces blood flow to the kidneys. It does have gastric effects. The problem in our patients, it can cause GI upset even at therapeutic doses, and severe gastric ulceration in some dogs. Problem is, you don't know until you've given it to them whether they are going to have a problem or not. There's a very narrow safety margin in cats. It's just not a good drug to use in our patients. We have much better ones. Piroxicam, also another human medication. It's only comes in the oral form. The ones we've talked about so far also causes vomiting, diarrhea, gastric ulceration, but it is useful for treatment of bladder tumors. There's, I'll tell you later, a newer, better drug, but for a long time, bladder tumors, our go-to treatment was piroxicam. And what it does is it is excreted through the kidneys in an unmetabolized, unchanged form. So it goes into that bladder in its totally active form. And the big thing with bladder tumors is they bleed like crazy, and they get all swollen up from inflammation. So the piroxicam, because it reduces the inflammation, stops the bleeding, so they don't have symptoms. They don't have a lot of blood in their urine. They're less likely to get infected because the blood isn't feeding bacteria, but also makes them much more comfortable. And most animals that have to get euthanized with a bladder tumor, it's because the tumor is either so painful to them that they are no longer have a good quality of life, or it has gotten so big that it's blocking their urethra. These tumors grow mostly in the neck of the bladder anyway, and by giving them this NSAID, it reduces the size of the tumor so they can have a longer, comfortable life. Carprofen. Carprofen was the first good NSAID that was designed just for animals. It comes in oral and injectable forms. Brand name is Rimadyl. Lots of other brands out there now because the patent is off on Rimadyl now. It's less potential for gastric ulceration. Doesn't mean it won't cause it. It's just less potential. Some dogs are more sensitive than others. It does cause renal toxicity with chronic use, especially in older animals who have renal function. So we usually have a lower dose. The dose for chronic pain is about half of what we use for acute pain. Does cause GI ulceration in cats with chronic use. We used to use this fairly, not really chronically in cats, but we would use it more in cats than we do now, but it causes more problems for them. There is a special in the breed thing with Labradors, and it's not every Labrador, it's not even most Labradors, but it's hard to predict who will have it, that they get hepatocellular toxicosis. And the problem is you don't know it until the symptoms are pretty advanced and until the damage to the liver has already been done. So when they first came out with this, they had done the safety studies and not seen this at all, but laboratory dogs are almost all beagles, and beagles are not don't have this genetic problem that makes this bad for them. But when they started giving it to older dogs with arthritis, guess who we're talking about? Labradors, big dogs, hip dysplastic dogs. There came some dogs that died from the Rimadyl. So a lot of doctors just won't use Rimadyl in Labradors anymore. Some doctors don't like it at all. They use other things. We've got lots of options now. But it's a good analgesic. Meloxicam comes in oral and injectable. The brand name is Medicam. It's less potential for gastric ulceration and renal toxicity. It does have some hepatic side effects in some dogs I have seen. It may cause vomiting, diarrhea, and inappetence, and these are all dose related. I really like this NSAID in cats. It's the one that we send home with our cats after surgery. The cats like it. It's not objectionable taste. It comes in a pretty good tasting form. My cat has been on it chronically for years now. She's got arthritis and she is in early renal failure, which is, we're going on year 3 of early renal failure. And she gets it twice a week. Sometimes I forget. And she loves it. I open the bottle, she comes running because she likes well, not running anymore, she's 19, but she certainly comes over and is anxious to get her dose. But the oral is off-label use in cats. They probably, the patent's off on Medicam for cats, so they probably will never go for a label. But in veterinary medicine, we use a lot of drugs off-label, and that's okay. Just because it's being used off-label doesn't mean that it is improper. That is, for our use in veterinary medicine, a lot of the drugs that were designed for humans that we know are useful and effective in animals are never going to be approved for use in animals, because remember when we talked about in the Intro to Farm video lecture, we talked about how much it costs to get a drug approved for use in whether it's animals or humans, millions of dollars. So to take a drug that's already available as a generic on the market and do those millions of dollars of study to get it approved through the FDA as this drug is useful in cats and safe in cats, it's just not going to happen. So we use those drugs, and that's okay to be used off-label. It's not just a under the table, don't tell anybody thing. It is authorized for veterinarians to do that. All right, Daracoxib comes in oral form only. Correct me if I'm wrong. I know they were in the process of getting an injectable for Daramax, but I don't know if that's been approved yet. This one does the same thing for bladder tumors. So this is a drug that is made for dogs, and it is safer than the piroxicam, and it is the same kind of effective on bladder tumors. So the piroxicam is, although it's less expensive, it is not used nearly as much because it's safer. It can cause some gastric ulceration, renal toxicity. You're going to get those side effects from NSAIDs. That's why we generally, if we're going to give this long term, we give a loading dose, it's called, which isn't necessarily actually a loading dose. We just do the starting out dose and get them so they are more comfortable. 3 or 4 days of that higher dose. And then we start backing off. We start cutting the dose down by a third or so, cutting it down by a half, and getting to the point where we can give enough to keep them comfortable without giving them enough to make them sick, which can be a little tricky, but most of the time the owners are very aware. Okay, we're only giving it every other day now and that seems to make him just fine, help him just fine. But we know if we forget on the third day, he lets us know because he's painful again. So then we remember to give him the drug. Thyrocoxib is available only as an oral only. That's Previcox. Same side effects, good analgesia, and the nice thing about having the variety of NSAIDs that we can use, some animals will work well. Dogs may work. Some dogs work great with Previcox. Some dogs, it doesn't seem to help them. They're better on Duramax. And so you've got that option to try a couple different ones till you get the one that works. Onsior, available in oral and injectable. It's the only NSAID label that's NSAID that's got label for unrestricted use in felines. So this is the drug that we can send home for our cats. We did I think I told you we did the clinical trials for this one, and none of the cats, while we had them in the hospital, and I had to dose them every day for 3 days, none of them would eat the tablet, which kind of surprised the researchers when they got that information. But at home, they say that most cats will eat the tablet. It's very palatable. Hopefully they're actually eating it, not just hiding it somewhere. It has the same side effects, but it's a good analgesic. The only 100% analgesic is a local anesthesia because it totally prevents transmission of those nerve impulses. So our other drugs work to lessen the impulse, to lessen the stimulation by lessening the inflammation. Our opioids block the brain's reception of those impulses, but local anesthetics stop that nerve impulse dead. I need to add gabapentin to this lecture. I didn't think about that. Gabapentin also interferes with nerve impulse transmission. So, but not to the effect of a local anesthetic. So doing that local anesthetic at the time of surgery, we put in the testicular block in the males when we're going to do a neuter, and we put it in the testicle and the testicle is leaving. What's the point? But we put it in the testicle so it goes up the spermatic cord because they know that in the surgery, that's the painful part of that surgery down the road is that crushing and cutting that spermatic cord. So by putting our local analgesia or local anesthetic up there, it numbs that, and that's numb for several hours. By the time that local wears off, the nerve, everything is calmed down, so the nerves don't get that acute bam, something really hurts here. You can do an intercostal, so between the ribs, nerve block of bupivacaine after thoracic surgery, because with thoracic surgery it's painful. You've cut through the muscles that operate the ribs, so it hurts to breathe. By using that local block, we take away the pain from breathing, because it's really important that our patient breathe deeply after they wake up, otherwise they end up with pneumonia. You can also do it intrapleural if you've been in the thorax and you're putting in a chest tube, which we usually do, put in a chest tube to evacuate all the air that gets in. You can put the bupivacaine through that chest tube into the thoracic cavity and move the animal around so that gets kind of coats the whole thoracic, or not the whole pleura, the inside, the lining of the thoracic cavity, and makes breathing much more comfortable for those patients. If you're doing an amputation, if you block those nerves before they ever get cut, it reduces the pain sensation, but it also reduces that phantom pain that people get with amputation. And we can assume that our patients get it too, even though we can't prove it. It feels like that limb is still there and that limb is painful. Ring block for a declaw. I know there's a lot of controversy these days about declaws, and it's probably going to get outlawed one of these days. But as of now, we're still doing them. I don't know how, anyway, I don't want to go down that rabbit trail. But putting a block of local anesthetic all the way around that leg, or blocking the individual nerves that go down to the foot, those cats wake up so comfortable, so much better than the old days when we didn't do that. When you're doing I say you, I mean you're doing the anesthesia, doctor's doing a joint surgery, and they put that local in the joint as they're closing it up. Really helps to reduce that pain post-op. Our line blocks that we use in our surgery lab, testicular blocks, oral blocks. Those of you who have seen some dentals that we've done, putting in those oral blocks makes the animal wake up so much more comfortably. An epidural, regional anesthesia, which we will, I don't think we've covered that yet in horses. Maybe we have. We do a lot of those epidurals or nerve blocks in our large animal patients so that we can work on them without totally anesthetizing them and laying them down, because that leads to a lot of problems in our large animal patients. So think about these things. These are really great ways to reduce the pain in our patients without causing too much bad side effects. Lidocaine has short action, short onset, but can be used in a CRI. You can give systemic lidocaine, and it works on pain throughout the whole body. This is really nice for pancreatitis dogs who have such extreme abdominal pain. This IV lidocaine, it does sedate them somewhat, but it makes them much, much more comfortable, and they're going to heal faster if they're less painful. Bupivacaine should never go IV. Now, don't get this mixed up. Bupivacaine is not butorphanol or buprenorphine. It is a local anesthetic, and it's cardiotoxic if it's given IV, so we don't want to send it directly to the heart. Has a slower onset and longer duration. So what we do sometimes is put these two drugs together, the lidocaine so we get the quicker action, and the bupivacaine so we get the longer. The lidocaine gives you quicker onset. The bupivacaine gives us longer duration. There's some controversy about whether that's really true or not, but it's still commonly done. Remember, local anesthetics, though they are safe, they are not foolproof. You can overdose a patient to the point where you kill them. It can be, overdosing them causes first CNS and cardiovascular effects. So what we see is a patient who has CNS signs. I had a dog, a husky, and this has been a couple years ago. I gave it a local block because I was doing some dental extractions, and it must have gotten some of it IV unintentionally, and the heart rate immediately dropped in half. And I was like, what the heck? What's going on? It took me a little bit of time to put together that it was that local getting IV that caused that problem. It was a fairly short duration. I gave the dog atropine, increased its heart rate. Everything turned out fine in the end, but that could have been, if I had given the full dose, and I use pretty small doses in my local blocks, if I'd given a bigger dose or given the whole dose IV, I could have killed my patient. So you have to be careful with it. Know your maximums. Maximum dose of lidocaine is 8 mg per kg in a, if you're given sub-Q, 2 mg per kg if you're giving it IV. Cats, 4 mg per kg. So as usual, cats have about half the dose of dogs that they can tolerate. Bupivacaine needs to go sub-Q or IM only. 2 mg per kg in dogs, 1 mg per kg in cats. Remember that the bupivacaine is much lower concentration than lidocaine. So to get that same dose, we need to give a higher volume. So be aware that you're not looking at two drugs that are the same there. You're going to give much less volume of lidocaine than you are bupivacaine. This website at the bottom there, this is veterinary anesthetic anesthesiologist group, and they have a lot of great information on there. If you're into anesthesia, that's the place to go to get all your answers. They have from the relatively simple to the really complex explanations for it too. So go look at that, and that particularly is for local anesthetics if you need some ideas or some ammunition to get your boss to try something new. Epidurals are putting a local anesthetic in, like bupivacaine or lidocaine, into that epidural space. That's going to numb the whole caudal half of the animal. It has a long duration. Because the spinal cord doesn't have circulation, it takes a lot longer for that drug to be moved from that epidural area out into the body to be metabolized and excreted. So you get a long 24 hours duration of that anesthesia. It's great pain control perioperatively. It also causes total inability to move those limbs. So you have to think about, my patient is going to wake up and be numb. It's especially important if you're going to use this in a large animal. You have to be prepared that they are not going to be able to walk. A problem that we run into with dogs especially, but also with cats, when we have given them an epidural that makes their back end numb, they don't recognize that those limbs are their own. I had a brachial plexus block. I had surgery on my hand, and I can attest to that. I knew that was my hand. I knew that was my arm, but it did not feel. I had no sensation of owning that arm. It was really crazy. I would be sitting there for a while. I had my arm propped up on a pillow, and I would get up to go do something, and my arm would just flop because I had no control over it. So with our patients, sometimes when that really freaks them out and they start mutilating themselves, they're like, "What is that?" and "Get it off of me!" and they start chewing on themselves. They can't feel it. So we have to make sure that we keep them tranquilized during the duration of that local anesthetic. The other thing is, I had some significant, as it was wearing off, not only was I starting to feel the pain in my hand, but my whole arm was uncomfortable. I wouldn't say it was painful, but it was uncomfortable. So that made me aware of what my patients are going through also when we've numbed them up. Regional analgesia is so we're doing the same kind of thing. We're putting a drug in the epidural space, but in this case, we're using an opioid instead of anesthetic. And what this does is gives you analgesia for a long time at a much lower dose than it would if we gave it to them IV. Remember, it's going to block those pain receptors in the spinal cord too. So it makes them, reduces their pain, especially for orthopedic surgeries in the back end. This is such a great tool. You put it in the epidural space of the lumbosacral junction, and analgesia to the hind limbs, abdomen, even up to the caudal thorax, the pelvis, and the tail. Nice analgesia without total disuse. They can still move their legs. They're going to be a little more, they're slower to react, but they're not going to have that numbness and that feeling of that, what is that? It doesn't belong to me. May cause urinary retention for about 24 hours, and that is not because they can't pee. It's because they do not feel the sensation to pee. All right, here we go. Reference texts. I talked a lot on this one. I hope the information was useful and valuable to you. We'll go over more in lecture on Monday and talk about all the different things and how we put things together. Thanks for watching.